many people out there who are innovating, changing how we practice and treat oncology patients. So, very grateful for this opportunity.
The question was, how long does it take for a 4 to 5 centimeter gist? So that was actually 4.8 centimeters is downsized. So I think just a couple of things. One, if it's greater than 3 centimeters, you're gonna have a hard time getting out the GE junction. So that you need to be aware of. So there's 2 options there if it's greater than that. One is to actually ask for, at the very end of the case, a single incision and put it through a gastrotomy. Or 2, you could have to bisect the lesion, but again, my practice is not to do that. So I typically try to, if they're greater than 3 centimeters, I usually will punt it back to the surgeon and say, hey, is there some other way that we can combine if you feel like it's not in an optimal spot so that you can be less invasive? I think with the advent of the robot, to be honest with you, we were doing less and less combined, and it was typically on the lesser curvature. As far as time frame for something like that, it's a learning curve, to be honest with you. So I think if anyone's like gone from laparoscopy to robot, there's a learning curve. They're longer, and then it gets faster. I typically will book a case like that for worst case scenario, so I book it for like 3 hours, but it's not usually that long, to be honest with you. The time goes down depending on certain factors. I think one factor is, how much has it been manipulated before? So you get a lot of fibrosis when it was prior manipulation, or again, gleevec, it can be tough, or if it's been radiated on. And then number 2, the location. And then finally, it's the amount of vasculature you run into.
All right, thank you. I have to ask you for advice on gastric stir too. So for my case, I'll just be talking about what we do with endoscopy after TNT for locally advanced rectal cancer disclosures. So pretty much, the case is a 61-year-old gentleman who presents for restaging flex sig. His oncological history of locally advanced rectal cancer, T3N1 M0, completed chemoradiation, and then systemic chemo with Kpox. And on restaging, a couple months later, he had MRI showing a complete radiologic response, a CT chest showing no metastatic disease, and a colonoscopy showing a sessile scarred down polyp in the rectum. So as you can see here on the left, this is initial staging. There's a granular lateral spreading tumor with a big nodular component, and then there was some area of an amorphous mucosal pattern, so suggestive of at least deep submucosal invasive disease. And on MRI rectum, it actually goes through the muscularis propria, so T3, and then had about 1 to 3 suspicious lymph nodes, so N1, M0 disease. And compared to the restaging, you see this sort of a flat, kind of sessile, scarred down lesion rectum, simply smaller in size, 3 centimeters down from 7 centimeters, without any ulceration or signs of deeper invasion. And on MRI, there's no viable tumor. So what next? I'll skip ahead. Well, like Dr. Gorgun said, there's a role for salvage ESD, pretty much resecting this and pretty much seeing if there's complete pathological response. So typically, I look under NBI, see if there's any signs of deeper invasion. I mark with a wider area in case there's any risk of tumor scatter, because originally the lesion was a little bigger. I'll do a submucosal injection, it's quite important. It allows me that submucosal space, but you can see right in the middle, it's quite scarred down. For these, I like to use the pocket creation method because it does allow me to kind of start out a little further away from the scar to create a submucosal pocket, so I have that space. And then once I reach the area of the most of the blood of the radiation, I could clearly define the planes a little bit better. But sometimes I will have to do an intramuscular dissection as well. So this is creating a pocket, trimming the mucosal sort of incision, and then now in it, doing some mucosal dissection. And sometimes these can be quite fibrotic. This one actually wasn't that fibrotic. So bottom part, you could kind of see some muscle. Those are the thicker sort of fibers. So I'm constantly injecting while I'm doing dissection to create that plane. So yeah, that's the pocket. And pretty much at the end, once I reach the other side, I just open up the edges. And to here, I just stick out the knife a little bit more because I'm in a safer plane. So yeah, so typically they can be quite difficult or quite vascular, but they're technically usually not very large. So that's a sort of post-ESD defect. And actually, our pathologists don't like to pin them down, but I agree that they should be pinned down. All right, so pretty much it came back as a TVA with focal high-grade dysplasia. The margins were negative. So after all these, I go back to a multidisciplinary discussion, and the plan was to go for a watch and wait option. And patient, a few months later, had another flex sig showing a rectal scar that was biopsy. That's a picture after biopsies. That pretty much didn't show any neoplastic tissue. And had MRI showing continued complete radiologic response. So this has been discussed. TNT is this great response from it. So if there's a clinical response, you can consider surveillance. But there are also studies, pathology studies, showing that after clinically responsive cancers, you can get replacement of neoplastic glands, but also retention of the adenomatous tissue. And these typically may be resistant to systemic chemotherapy and radiation because they lack the insufficient, basically, proliferation rates. So what do we do about this? It could harbor some foci of cancer, or it could be complete adenomatous, which eventually may become a cancer. So surgery is one way to sort of resect it. Another sort of organ-preserving method, and also reduce the risk, or to preserve the planes, reduce the risk of like a post-LAR syndrome, is to do ESD on these. So with ESD, you get pretty much the whole tissue. You could analyze for any residual cancer, and also eliminate the residual adenoma to avoid recurrence. So this is another example. So this one actually did look a little bit concerning. There was a little area of kind of depression here, but when they biopsied it, actually didn't show any carcinoma. So I decided to do ESD for this one to get more tissue. And here I actually had to do an intramuscular dissection. And then, like Dr. Sharma said, the suturing actually was quite nice. So I closed it up. Patient was discharged the next morning. This, unfortunately, did come back as residual cancer. So they went for APR. This is quick. Maybe a little typo here, should be for TNT. But when I was at Sloan, before coming to Penn, they would start doing these studies comparing sort of, well, now they started doing some studies comparing salvage ESD after TNT compared to surgery. I'll skip over a lot of this because it's been reiterated. But pretty much, the short-term recurrence rates were low. What was noticeable was that the group in the salvage ESD, most of them had pretty much transformed into adenomas. All the ones that went for surgery were still adenocarcinomas. So the key point is careful multidisciplinary discussion to figure out which ones are more likely just adenomatous tissue without any signs of invasive disease, without distant disease. Those can potentially go for salvage ESD, while others should go for sort of standard surgical resection. So pretty much at Penn, I kind of adopted sort of that strategy. So pretty much patients with locally advanced rectal cancer, they get sort of systemic chemo and chemoradiation. They get the restaging. As long as there's no signs of invasive disease, meaning on endoscopy, there's no fixed mass, no ulceration. On MRI, there's no viable tumor. And there's no distant disease, then after multidisciplinary discussion, carefully selected patients can undergo ESD to assess for, if there's some residual mucosal lesion, to assess for any residual carcinoma, and to basically take out the residual adenoma if that's the case. So if there's no pathological complete response, to go back to multidisciplinary discussion, surgery. If there's complete pathological response, I usually just also go back to multidisciplinary discussion, and then typically they go for surveillance. But close surveillance is very important for these. So. And these are my mentors, colleagues from Sloan Kettering and at Penn. And thank you.
We have a few minutes for questions. While we have people come up, one interesting observation I wanted to kind of highlight with all the interventional endoscopy folks in the room is, in some of the new adjuvant studies that we have published on MSS colorectal cancer with some novel immunotherapeutic agents, again, these are not the MSI high that are responsive to checkpoint blockade. Even when they have residual tumors, it's what we call an inside-out response. So they were truly downstage from like a T4 to a T1, T2 residual adenocarcinoma. So, one of the things I've been talking to our GI other colleagues is, I think traditional chemoradiation is very different. If you have residual tumors, kind of could be everywhere. With these novel immunotherapeutic agents, it's like an inside-out response. So truly, the residual tumor might be amenable to an endoscopic type of procedure, whereas you could be more confident that you didn't leave stuff behind. So just kind of wanted to kind of highlight that observation too.
Sorry, thoughts on the use of circulating tumor DNA and after endoscopic resection for risk stratification of patients, and also in situations like these to guide should the patients.
I think one of the cases that Sharma also mentioned, we wrote a grant together with some of our colleagues at Cornell looking at, is the patient who might have had endoscopic resection, does that person still need the surgery part? For the most part, they'll still go for surgery, they're a surgical candidate, but often you have no residual tumor, how do we pick those patients? So I think the assays would have to be, I would say, better. Now the folks from Canada at ASCO GI a few months ago did show with their own assay almost a 44% detection rate in early stage rectal cancer. So I guess we're getting there. I think right now it's kind of in the research realm where it will be helpful to use that as an adjunct or even as some of these assays are commercially available to have them be done pre and post some of your procedures. So we've been trying to piggyback that in our clinical practice, but I think outside of the clinical trial, we're in the data gathering zone, but it's a unique opportunity as the assays are getting really more sensitive.
Maybe even before they get more sensitive, you mentioned this yesterday, ultrasound can be more sensitive. When we take a look at the data that you presented in combination of sigmoidoscopy and MRI, what I noticed glaringly missing, and this is also in the Sano trial, which I actually talked to that cohort when they presented at GI ASCO and at ESG, EOS is underutilized in these studies. So I wonder if there's a step-up approach adding EOS to this with some of the novel imaging modalities coming in combination of sigmoidoscopy and MRI until you get assays that are really valid.
And I will piggyback on what Dr. Lin was saying earlier too. I don't think we have to pick either or. Like your data on the MR response picked up patients that ctDNA missed, and by combining that, you were going to like an OS of 100% prediction. So we have all these things in the same patient. So whether it's endoscopic, MR-guided response assessment, or MRD assessment, I think they could have a better sensitivity if you use the clinical variables. One of the things I liked about the Australian study for rectal cancer, what they did was they just didn't use the ctDNA to guide adjuvant chemo. This is again was done in pre-TNT era, so they had to stop the study halfway once paradigm shifted to moving chemo pre-surgery. But what they did was, even if your ctDNA was negative but your pathology was bad, you still got adjuvant chemo. So that's where we have to be mindful of not forgetting the clinical variables and include that into the decision making.
I guess the final question, Dr. Luyimbazi, like when you see where endoscopists are going, do you see a partner? Do you see a competitor? How do you feel? Yeah.
So that's an excellent question, and I've been thinking through this. First off, we need to realize a couple of things. We're dealing with esophageal cancer. We're dealing with lesions at the GU junction. We're dealing with rectal cancer. These are lesions that typically occur in patients with a significant amount of morbidity. Okay, and in most of the times we're looking at patients who are above the age of 70 and who have significant comorbidities. And so with what I'm hearing today, and the key thing being a multidisciplinary approach to doing things, I am in awe of what you guys can do with a scope, and I think it's a win-win situation for our patients. But the key thing, once again, is making sure we have an acceptable global definition of multidisciplinary, meaning when you walk into that meeting, it's not enough to just have a medical oncologist and an interventional GI. It needs to be a surgical oncologist, preferably surgical oncologist. We could certainly have a general surgeon, but someone who lives and breathes this on a regular basis. It needs to be a pathologist and so forth. Things that those of us who are in these institutions take for granted. It really needs to be defined, and if there is no quorum, if a medical oncologist is missing, then we really shouldn't be discussing this kind of patient. But I without question, see positives here. Yeah.
Just speak up. So two questions. One for organ preservation and esophageal cancer. You know, what we're seeing from the recent trials, Top Cure, Neo-Ages, the PCR rates are in like 15%, 16%, 9%. And I think that remains a bigger problem when it comes to looking at organ preservation. So I think the thoughts which the panel may have on what are we looking at as we look at organ preservation in esophageal cancer, what's going to help us increase those PCR rates which would correlate to organ preservation, as opposed to overall survival, which I know is a good endpoint, but ultimately for organ preservation we need the PCR.
But of course, I think you're alluding to chemo, right? 16% was chemotherapy. The chemo radiation, of course, it's always been. I think SFEC was an outlier, right? Even actually, if you look at dose, I mean, there were studies where they compared chemo radiation to perioperative chemotherapy, and they were only using 30-grade chemo radiation, and they had 15% PCR. So SFEC is a complete outlier. No other trials have seen such low PCR rates. And so, but if you look at all the other studies, including Top Gear and Neo-Ages, and it's Top Gear is actually more gastric, right? It's kind of 25% esophagus, but it's 25% or so, and much higher with spleens. So I think that kind of mimics, the PCR rate for that you see for rectal cancer. I think kind of like 25%, 30%, 25%. I think there's room to improve on that, and obviously there are, these tumors, they're non-responders, right? They're complete responders, and of course those ones do not respond. And there's actually some radiation-resistant mechanisms, and we have a paper that's actually in Present Cancer Cell. Actually, we found some of these mechanisms through single-cell sequencing and preclinical validation in esophageal cancer, showing that some of these mechanisms can be targeted to convert resistance to sensitivity in preclinical models. Obviously, we have to test it in clinical studies, and so we just got a grant actually to potentially test this. But again, these are research, right? But I think there is room potentially to target and enhance chemo radiation responses and enhance organ preservation.
I guess it'll be. I guess we wait to see if addition of immunotherapy in the future at some point in neoadjuvant may help. I think I had a second question for post-TNT, wait and watch, local regrowth. We do an ESD, and you find some focal areas of cancer. By guidelines, by trials, goal would be to recommend a TME at that point. Are the institutions which are looking at, listen, we're just gonna, it's small amounts, we got it, we're gonna watch? How are we approaching that?
Yeah, absolutely. This is, of course, a little bit future direction or innovative, outside the box. And we tell our fellows, for example, do not give this answer at your boards. You don't want to say, even for like a high-grade dysplasia, it's not the standard. But if you find tumor or cancer, invasive cancer, absolutely, then at the moment we do recommend that. Having said that, even in our series, we have had a few patients that had cancer and then subsequent TME, there was no residual disease. But I think it brings us back to the circulating DNA and better markers, like flexible endoscopy, MRI, and then additional markers. I think those gonna help us to increase the, our assessment and sensitivity and specificity in this realm. One additional thing, congratulations, that was awesome, that lesion was really big and successfully done. One word of caution is I would be a little bit careful. Intramuscular, I think we can leave these open. If we full thickness, maybe closure might be a little better, but one concern I always have with leaving the overstitches, you leave a metal back there. And in these patients, as long as you don't find any cancer, in that case you did find cancer, but they will be monitored for long term. And then it's, you lose those patients for MRI, it creates a lot of artifact. I think that's one thing, maybe endorobot helps there without leaving any more metal. If you have deeper, then you can just close them without any metal.
Dr. Smith?
Yeah, no, I completely agree, and I've encountered that issue where they try to survey your MRI. So I've actually gone back, pretty much cut the sutures. There's two metal parts. There's one needle tip, and then the cinch. So,
Smith, you had a
Just real quick on those lines, the option to potentially study doing FTRD in those patients. Obviously if they have to go for a bigger excision, that can be a bit of an issue, right? And it's like a bit of a violation, at least traditionally. I haven't talked about my ICER mentor, but it seems like there's an opportunity to study that for these patients. So we're doing ESD, but why not do a freehand transanal using the robot or using like our technique I showed? What would you think about that, or how would you design that study?
Yeah, I'm not sure if there's any value, respectfully speaking, because I think if you find, this is like an excisional biopsy in a way. It's an ESD, but we're trying to diagnose the tissue. If there's cancer, to the best of our knowledge, probably it's safest, as we spoke, to proceed with TME anyway. And if you do full thickness resection, we can do that transanally with TAMS, transanal minimally invasive surgery too. But then you violate these planes that then you end up, if you do surgery subsequently, incomplete mesorectal excision. Your margins are R0 resection is probably lower, and you go deeper, and the healing, or until you operate, there's a lot of scarring and colorectal anastomosis. You may even cut that bridge, the possibility to do that. And those patients sometimes need APR, even though not oncologically, but technically, the area is damaged from full thickness excision.